I get the pleasure of presenting Professor Adrian Bosenberg to you. He is an honorary member, APA of Great Britain and Ireland, honorary member of European Society of Pediatric Anaesthesia. For me, he is the first person who ever put the thought of pediatric regional anesthesia in my head through lots and lots of literature that he has written. It's such a pleasure seeing you here, sir.
Thanks, Roshali. It's a pleasure being here. It's always a pleasure coming to India, not only for the food, but at these meetings I learn a tremendous amount. So thank you for all the speakers and for everybody here who I've had an opportunity to have an interchange with. So my task is to talk after Professor Harrop Griffiths, which is never easy, but it's to talk something about my passion, which is the little people, the neonates. We know that the surgeons cause pain, or do we know that? And it's only been in the recent past that we've changed our mind about whether babies feel pain, but we'll get on to that. My objectives of this talk is to review some of the benefits of regional anesthesia in neonates, infants, to outline some of the problems, the alternative techniques of managing pain through opiates, and focus on the prematures and premature babies and neonates, and offer a strategy to minimize the hot topic at the moment, which is neurotoxicity in ex-prem babies and neonates following general anesthesia, and also to touch on the risks of regional anesthesia. In doing so, I have no disclosures, but I have a definite bias towards regional anesthesia, and I have a passion for the little ones. So to start off with, pain and stress are something that we want to minimize. But as I said, it's not a new thing. Previously, when I started out as an anesthesiologist, and just prior to my fellowship in Seattle in 1983 and 84, there was a belief that children didn't feel pain, and you didn't find the word pain in any pediatric surgical textbooks. This month in anesthesiology, you'll find a reprint of a paper that was published in 1987, which is entitled Discovering Pain in Newborn Infants. And it was a paper done by Sunny Anand and others, where there was, at the time, nitrous oxide and muscle relaxants were used, but no analgesia or no opiates were given. So what they did was to compare, it was a small study, 8 of these babies was given fentanyl at 10 mics per kilo, and 8 were given the standard anesthetic of the time. And what they found was that the patients, or the babies who had no fentanyl, the metabolic and circulatory problems were significant, and those associated who had fentanyl was associated with an improved outcome and, as subsequently found, better survival. So simply treating pain is obviously something that has changed, and this is a seminal paper which is worth reading, because nowadays, and many of you in this room, I believe, were born after 1987. So what does surgery do? It creates a stress response, and that causes a whole bunch of a spectrum of problems: autonomic, metabolic, hormonal, immunologic and inflammatory, and neurobehavioral. Neonates and prematures down to about 26 weeks or even earlier than that can mount a stress response. A stress response is bad news and is related to surgical stress. The more severe the stress, it becomes pathological, and with extreme catecholamine release or response, you have the worst outcome. So treating pain is useful and important. The detrimental effects of pain have also been shown to cause neurodevelopmental impairment and altered pain sensitivity. In the long term, it can cause emotional and behavioral disturbances and learning disabilities. Acute pain has negative physiological consequences, respiratory impairment, systemic and pulmonary hypertension and vasoconstriction, and a negative impact on the immature and compromised organ function. The gold standard, certainly in the States, is to use morphine. But to provide adequate analgesia, you need a continuous infusion. By simply giving intermittent doses, you're going to have peaks and troughs, and the baby will still be subjected to intervals of pain. To use an adequate amount of analgesia provided by morphine, it mandates ventilatory support. And in many of our institutions, certainly ones that I've worked in, we didn't have the ability to place a baby on a ventilator. And if you did, there was a significant morbidity and mortality. There are side effects to morphine, as we all know: sedation, hypertension, nausea, vomiting, pruritus. It's difficult to assess in neonates, but is usually presented as the child being fussy and irritable. And when a child is in a neonatal unit is fussy and irritable, it usually indicates the nurse is going to give you more morphine. Morphine also causes tolerance, which requires more and can cause dependence. So paradoxically, morphine can induce hyperalgesia because of the tolerance. It desensitizes the opioid receptors, upregulates the cyclic AMP receptors, and consequently you need increasing doses. With the result that in the NICUs, neonatal intensive cares, around the United States, the incidence of addiction becomes high. It's around about 1/3 to 50%, depending on the unit that you work in. And it causes a significant withdrawal may occur after about 5 days, which in itself has its own problems. It's greater in the premature baby because they have immature enzymes and they metabolize morphine to morphine 3-glucuronide, which actually antagonizes the effect of morphine. So that's why I personally don't like using morphine. Obviously I do if I have to, but I much prefer using regional anesthesia. So why regional anesthesia? The opinions differ. There's an article by Moriarty who came up in praise of the epidural space for neonates. On the other hand, Martin Jure, in a publication of the best practice at the time, felt that direct thoracic epidurals should only be performed exceptionally in neonates. You need to be an expert, he felt, and it is his belief that there's no place for use of this technique in neonatal surgery, and he felt that it was simply easier to give opioids, and he admitted that it was difficult to give it in a spontaneously breathing neonate, but he had an ICU and so could simply put these kids on a ventilator overnight and they would do well. I could not do that in my practice, as I've alluded to already. That's my former practice. So regional anesthesia, to my mind, has many advantages. It provides profound analgesia, it reduces the MAC under anesthesia, and we tend to use regional anesthesia in combination with general anesthesia. It always has remarkable hemodynamic stability, and this occurs even in the cyanotic heart disease or in situations with a fixed cardiac output. I've been in situations where a child has had cardiac tamponade because of sepsis, placed an epidural. There was no change in the blood pressure whatsoever, and the child did extremely well. I did not have an ICU bed, and that's why I ended up doing an epidural. The other value of regional anesthesia is that it doesn't cause any respiratory depression. It's better than opiates in inhibiting the stress response, and it can improve the immune response in many situations. There's less need for ICU, less need for post-operative ventilation. There's less blood loss, and improves has an effect on the return of gut function in that it reduces the time to return to normal motility of the gut. In situations where the baby may present with NEC, necrotizing enterocolitis, it'll improve the perfusion and may help salvage the gut. Regional anesthesia is also more effective in inhibiting the stress response. It has less immunosuppressant effects, which you will find with opioids. Local anesthetics also have an antimicrobial property and inhibit bacterial growth, which may have been, I've always been told by the surgeon you shouldn't infiltrate the skin because you're going to increase infection. Not true. Infiltrating the incision, you actually improve the chances of less infection. Now, as far as regional is concerned, if you believe that the microglial activity is an indicator of the nociception being interfered with, this shows a paper that was published some years ago now, 2010, where they gave a single shot sciatic nerve block to a rat. They couldn't put a catheter. Obviously, they couldn't find a catheter that's small enough for a rat, so they did repeated blocks. And they found that with the increase in microglial activity, you'll see, as you see in the bottom, the red in the bottom picture, if you did a block, you ended up without the increase in microglial activity, suggesting that the regional anesthesia has some benefit. The extreme premature baby or the ex-premature baby, there are many issues. Neurotoxicity is one of them, which is many publications, particularly in the animal model, that shows that there's neurotoxicity related to general anesthetics, to ketamine, to the benzodiazepines, and also the concern about apnea in the ex-premature baby. And this all started back in 1983. That was when they were still using just muscle relaxants and nitrous oxide. There was a large incidence of complications, mainly respiratory, but occasionally bradycardias that occurred. Now, times have changed, but we do know that, as you can see, times have changed. My moustache is no longer red. But we have a better understanding of neonatal ventilation. We've had introduction of surfactant. We've also used gentle ventilation, and we see less bronchopulmonary dysplasia. All important in the development of the ex-premature baby that may need to be ventilated after birth. We also have better anesthetics, cleaner anesthetics, sevoflurane, desflurane, and remifentanil. And many have suggested there's no difference between doing a block and giving a general anesthetic using these agents. But I beg to differ. This is a composite graph of studies that were on ex-premature babies and the risk of apnea. The more premature you were, or you are, the more likely you are to have an episode of apnea. And also, if you were anemic, you were more likely to have an episode of apnea. However, in two large studies, the largest study being the GAS study, which was a multi-center study throughout the world, they found that there was only a difference in the first hour. So babies who had a block, they compared general anesthetic versus a block in an awake baby, and they found it was only the first hour that there was less apnea. Later on, it was much the same and statistically insignificant. However, there was the blood pressure, the hemodynamic stability was far better in the children who had a block or had a caudal or a spinal. As far as neurotoxicity is concerned, what they did was they compared the two and then looked at them at age 2 and at age 5. And I can tell you that after 1 hour of anesthetic, these studies showed that there was no difference between the regional anesthesia and general anesthesia as far as neurotoxicity is concerned. As far as I'm concerned, I don't believe that neurotoxicity is an issue, but the jury is still out on that. We've run out of time, but I can assure you that complications are very small. The biggest complication is usually that the catheter, because they're very small, tend to kink, they tend to dislodge, but that's the only major complication that you will see in neonates. I thank you for your attention and look forward to questions. No questions.
Any questions?
Good afternoon, sir. This is Dr. Anupama. This epidural, when you say for neonate, it's very difficult to gauge. You do it by loss of resistance. How do you do it?
I use loss of resistance to air. That's frowned upon, but people that do it regularly feel that air is more sensitive. The problem with using loss of resistance to saline is that in small babies, if you put 1 cc of saline into the epidural space, you dilute out your local anesthetic significantly. So that's why I use air. I don't use more than 0.5 ml of air, and if once you've detected the loss of resistance, if you then release the plunger on the syringe, you will notice that it comes back. So in fact, you're not actually injecting air into the epidural space, but
No, but even at thoracic, usually neonates, what we've been practicing is caudal, probably lumbar to some extent. Thoracic becomes quite a narrow gauge. So do you go in thoracic level directly?
I do, yes.
And gauge of the needle, what do you use?
I've used 19 gauge Portex back when I had it available in South Africa. And in Seattle, we're using a 20 gauge epidural kit for thoracics. Yes, you can use caudal. Passing a caudal catheter is something that we developed back in the day, in the mid-80s, when epidural kits were not available for children. And yes, it's used widely across the States and in Europe, and I know here in India. It is, you can use ultrasound to see where it's going, but when I first started using that technique, if you hit resistance, you don't want to force any catheter, because if you use force, it's going to turn up and curl. So you place the introducer in a position where the catheter will run, and if you do that in every situation where I've done contrast to see where the catheter is, it always is in the midline. One of the mistakes that people make is they use an epidural needle. Epidural needle is curved, so you have to line it up within the epidural space, otherwise it's simply going to curl and curl up in the space and it's not going to go where you want it to.
Thank you.
You're welcome.
Excuse me, sir. A small doubt, sir. Sir, is epidural blood patch technique, means, are you applying this for neonatal also? If you are puncturing the dura, what to do next?
Well, that's the beauty of neonates. They don't complain. So the hydrostatic pressure in a neonate, we always put the epidural in a horizontal position. The hydrostatic pressure is minimal. So yes, you might get CSF, but the need for a blood patch is, well, I've never read of one, I've never done one, I've never seen one, and I'm sure that the leak is insignificant compared to the turnover of CSF. A neonate produces a lot more CSF per hour than an adult does, and I think that's why, well, I don't know whether that's the reason why they don't complain of a headache. They simply don't complain.
So what is your suggestion if I am puncturing the dura once?
You have two choices. You can either go in a space higher or a space lower. I would tend to go higher, or abandon procedure. You don't want to puncture on a number of occasions. So it depends on your experience. You don't want to be in a situation where you've punctured the dura a couple of times. The incidence of dural puncture based on our PRAN network, where we've done neonates, there was 1% of the 104,000 patients. So there were, what's that, about 10,000? No, it's about 1,000 babies had regional anesthesia, and there were no dural punctures in that group. But yes, it does happen. I've seen it happen. I've had one where I was distracted. Somebody had called me to the telephone and I turned, and the next thing I had a dural puncture. So the focus is being gentle, being careful, and if you've punctured it once, you don't want to do it again. So I would abandon and go for a peripheral block.
Excuse me, sir. So I'm Dr. Prashant here.
Yes.
So when you're doing in the pediatric or the neonate, how much ml syringe you use to give the top up, sir? Was it the 2 ml or 5?
The top up of a caudal?
Yes, sir.
So if I use 1 ml per kg, so if you've got a 3 kilogram baby, the top up needs to be done at around about an hour and a half to 2 hours. It's much shorter in a small baby than in a prem, than it is in an older child. And then I give half the original dose. So if my original dose was 3 mils for a 3 kilogram baby, I'd use 1.5 mils.
Sir, no, I just wanted to know the syringe which you use.
Oh, the syringe. The syringe I use either, depending on the size of the baby, I'll use either a 3, 5 or a 10 mil syringe. Okay. In a small baby, the smallest caudal I've done was a 400 grammer. The smallest epidural that I've done is a 500 grammer. In those, both of those, I use 3 mil syringes. Yes. In the older kids, bigger babies, if it's 3 kilos, I'll use a 5 mil syringe. In the older babies, I use a 10 mil syringe.
Thank you, sir.
Thank you, Dr. Adrian.
Thank you.